Good morning. My name is Elizabeth Davis, and I am a sarcoma medical oncologist at Vanderbilt University Medical Center. I'd like to thank the organizers for inviting me to discuss updates in sarcoma. These are my disclosures. Today, I will review the definition of sarcoma with particular focus on the heterogeneity of this group of tumors and how now more than ever, we are appreciating these differences and incorporating them into trial design. I will also discuss the revised staging system and review treatment options. As a premise for today, it is necessary to define what distinguishes sarcomas from other cancers. They are neoplasms arising from connective tissue. The word sarcoma is Greek and means fleshy substance or harmful connective tissue. Classically, sarcomas are divided into two groups: soft tissue sarcoma, which comprises 80%, and bone, which accounts for 20% of cases. Within soft tissue sarcoma, there's significant heterogeneity with more than 100 subtypes and arising from all locations within the body. Here you see representative images from 6 people living with sarcoma. On the far left of your screen are 2 images of sarcomas arising within the oropharynx. In the middle of your screen on the top, you see a cardiac sarcoma. On the bottom middle, a sarcoma that's affecting the extremity. On the top right, a sarcoma that was resected from the abdomen. And on the bottom right, a sarcoma arising from the liver. When we think about how to define sarcomas, the classification is based on the presumptive tissue of origin as well as the architecture. For example, liposarcomas are tumors that resemble fat, leiomyosarcomas arising from smooth muscle, rhabdomyosarcoma arising from striated muscle, angiosarcomas arising from blood vessels, chondrosarcomas arising from cartilage, and osteosarcomas arising from bone. This pie chart displays the incidence of various sarcoma subtypes. On the far right in blue, you can see gastrointestinal stromal tumor, or GIST, unclassified sarcomas, and liposarcomas account for almost 50% of sarcoma cases. On the left side of the screen, in an array of different colors, you can see that there are numerous other histologies, but that there is a large group that is in fact incorporated into this very small pie piece labeled other. When we think about genetic abnormalities within sarcomas, we know about 1/3 of sarcomas are associated with a simple karyotypic abnormality, and another third are characterized by a specific mutational change. These mutational changes can be important as we think about oncogenic drivers, their help in allowing us to diagnose certain subtypes of sarcomas, and then potentially as therapeutic targets. On the far right, you see a chart with a small subset of the translocation sarcomas. There are far too many to list on one slide. Perhaps the most well-recognized, though, is on the bottom, infantile fibrosarcoma, which is characterized by a translocation between ETV6 and NTRK3. And the treatment of this disease has been revolutionized by the TRK inhibitors, which are particularly effective at targeting this translocation. When we think about the etiology of sarcomas, we know that the bulk of them occur sporadically. However, there are a handful of hereditary syndromes that predispose people to developing sarcomas, such as neurofibromatosis type 1, retinoblastoma, tuberous sclerosis, and Li-Fraumeni. There are also a variety of agents which can induce a sarcoma, such as radiation, certain chemicals, and chronic lymphedema, also known as Stewart-Treves syndrome. So how do we work up a suspected sarcoma? First and foremost, we start with a biopsy, and it's important to understand that FNA will almost never yield us a diagnosis. There's just not enough tissue within an FNA to give us all the information that we need. So core biopsy really is the gold standard for diagnosing sarcoma. It's important, though, to know the resection plan when biopsying a sarcoma, as this tract is prone to tumor recurrences and really should be resected along with the primary sarcoma. Open biopsy should be done in the hands of an experienced sarcoma surgeon, as we know that whoops procedures certainly lead to an increase in morbidity for our patients. Following a biopsy, expert pathology review is very important, especially given the heterogeneity within this group of cancers. And then imaging of at least the local site in the chest should be performed. There are some particular histologies for which additional imaging is indicated, but imaging of the local site in the chest should be performed at a minimum. The final step in this process is review by a multidisciplinary tumor board, as planning treatment for sarcomas is incredibly complex. Staging of sarcoma is very similar to other tumors in that it uses the AJCC TNM classification. However, there are some nuances, particularly within the T stage, which varies by primary sarcoma location and sometimes histology. Within this chart, you can see that tumor location, head, neck, extremity, trunk, and retroperitoneum are in one category, and the T stage is divided by size. Visceral organ T stage is defined of where the tumor is in terms of how much organ is involved. And for GIST, a very specific subtype of sarcoma, accounting for about a third of all sarcoma cases, is purely based on size. Nodal staging and MET staging are purely done by the presence or absence of these findings. And the final component of sarcoma staging is grading. And grading is probably unique to sarcoma relative to most other tumors, and that this actually has a very important role in the overall stage. So grading consists of three components: differentiation, mitotic count, and necrosis. And within each of these, the tumor can be given different points. And then the points from these three categories are added together, and the final grade is determined as 1, 2, or 3 based upon the score. GIST is slightly different in that we're merely factoring in low or high, and it's by whether the tumor has less than or equal to 5 mitoses per 5 millimeters squared or greater than 5 mitoses. So putting it all together, you can see stages 1 through 4 listed here. On the second column, you can see all locations, and then on the right 2 columns, you can see the staging for gastric and small intestinal GIST. So how do we treat this complex group of tumors? The most important thing to keep in mind is that treatment is very histology and site specific. This is definitely not a cancer where one size fits all. So if we think about what drugs have been approved for soft tissue sarcoma, in 1974, we first had doxorubicin, which is approved for all comers with metastatic soft tissue sarcoma. It was more than 25 years before we had another drug approved for our group of tumors. And that drug was imatinib, which received 2 indications. First, in 2001, it was approved for GIST, and then in 2006 for dermatofibrosarcoma protuberans, for DFSP. In 2006, we also saw the approval of sunitinib for GIST. And in 2012, Pazopanib was approved for non-liposarcoma soft tissue sarcoma. 2013, we had another drug for GIST, regorafenib. And then in 2015, trabectedin was approved for the L sarcomas, leiomyosarcoma and liposarcoma. And in 2016, another drug for liposarcoma, Eribulin. More recently, in 2019, pexidartinib was approved for the treatment of tenosynovial giant cell tumor. And 2020 was quite a year with the approval of 3 new agents: tazemetostat for epithelioid sarcoma, ripretinib, and avapritinib for GIST. So let's spend a few minutes talking about GIST, given that this accounts for about 30 or 40% of all sarcoma cases. Treatment for localized GIST includes surgery, and then either adjuvant imatinib based on risk stratification, or potentially neoadjuvant imatinib if resection would be particularly morbid. It's important to keep in mind, though, prior to prescribing any imatinib, mutational testing must be performed. When we look at mutations in GIST, they generally fall into one of 3 categories. The majority of GISTs have a KIT mutation, and then a smaller subset have either a PDGFR alpha mutation or potentially are in the category that we deem wild type. Within KIT, exon 11 is far and away the most commonly mutated finding, followed by exon 9, 8, 13, and 17 occur, but are much less common. Within the PDGFR alpha gene, the most important thing to remember is that the exon 18 D842V GIST are resistant to treatment with imatinib. And so it would never be appropriate to give a person with that mutation imatinib. The last category, these wild type GIST, can have lots of different abnormalities. However, they are defined by an absence of mutation in KIT and PDGFR alpha. So anything that has any other mutation in it would be deemed wild type. Things seen in this category are SDH deficiency, BRAF mutations, NF1, HRAS, NRAS, and NTRK. So when we're thinking about prognosticating and estimating recurrence risk for people with GIST, we use 4 factors: size, location, mitotic activity, and rupture. I like to use this heat map, which was published in 2012, to estimate recurrence risk, although there are numerous other GIST nomograms that can predict recurrence risk. But I like this one, and it's a good visual for patients as well. If you look on the top column, this is GIST where rupture is unknown. The middle row is GIST with no rupture, and the bottom is GIST that have ruptured. The far left column is those that had a gastric location. The middle column is their non-gastric, and the far right is extraintestinal GIST. On the x-axis of this, we have you have the tumor size from 0 to 25, and on the y-axis, you have mitotic activity from 0 to 50. The dark blue is the lowest risk of recurrence, and the deep red is the highest risk of recurrence. So if you take the patient's pathology report, you should be able to insert those factors into it and then determine their risk of recurrence. And so this is a useful tool when talking with a patient about the risks and benefits of adjuvant imatinib. This is the study that made adjuvant imatinib for high-risk GIST the standard of care and for a total duration of 3 years. In this study, they compared outcomes amongst high-risk GIST patients in terms of recurrence-free survival as well as overall survival treated with 1 versus 3 years of imatinib. And they found that outcomes for those treated with 3 years were superior. And so this has been the standard of care for almost a decade now. When we look at the treatment for metastatic GIST, imatinib at 400 milligrams daily is the standard of care, with the exception of those who have the PDGFR alpha D842V mutation. As of 2020, avapritinib is now the first-line standard of care for these patients. Second line, third line, and fourth line treatments are generally with the FDA-approved drugs sunitinib, regorafenib, and ripretinib. And after fourth line therapy, there are a multitude of TKIs that have some limited data suggesting efficacy, but a clinical trial at this stage would also be very appropriate. So let's talk for a little bit about non-GIST soft tissue sarcoma. So the first and foremost, the most important thing in this category is determination of a treatment plan by a multidisciplinary sarcoma team. For localized low-grade soft tissue sarcoma, the treatment generally includes surgery with or without radiation. For localized high-grade soft tissue sarcoma, though, things become a little bit more complicated. Patients can have surgery followed by radiation, or radiation followed by surgery with equivalent outcomes. And then the role of chemotherapy is controversial in this setting, and we'll go into that in just a bit. For metastatic or recurrent soft tissue sarcoma, chemotherapy is the gold standard. However, there may be a role for surgery and/or radiation depending upon the patient. When deciding whether or not a patient may benefit from adjuvant chemotherapy, it's important to consider tumor factors such as the sarcoma histology, the tumor size, the location of the primary tumor, as well as patient factors such as age, comorbidity, social circumstances, and patient preferences. There have been numerous studies looking at the benefit of adjuvant chemotherapy in localized soft tissue sarcoma. However, the results have been very mixed, thus leading to the controversy. This is the largest adjuvant study that has been performed in a soft tissue sarcoma, examining the role of 75 milligrams per meter squared of doxorubicin and 5 grams of ifosfamide in the adjuvant setting. In comparing 350 patients enrolled in this study between no chemo or chemo, there was no difference in terms of overall survival. However, this study received lots of criticism in terms of its findings due to the incorporation of lots of low-grade tumors, lots of small tumors, which in our world are anything less than 5 centimeters. The fact that 80% of patients, only 80% of patients received all 5 cycles, and that only 68% of patients received full dose therapy. And some may argue that 5 grams of ifosfamide is not truly full dose therapy. So within this study publication, though, they did conduct an updated analysis, and they incorporated the Sarcoma meta-analysis collaboration, which was published in 1997, as well as 3 other randomized trials of doxorubicin-based adjuvant chemotherapy. And when they used the survival results of all of these trials and incorporated the new EORTC study, the findings did suggest that there could be a benefit for adjuvant chemotherapy. And so that's represented at the bottom of this forest plot. So the controversy continues. In 2019, this paper was published, and they used an app called the Sarculator, which is free. You can download it to your phone. And it uses age, tumor grade, size, and histology. It's been validated both retrospectively and prospectively. And so this paper looked at using the Sarculator to reanalyze data from the EORTC study. And so they calculated predicted probability of overall survival using the Sarculator, and they grouped patients into 3 categories: high, intermediate, or low. And they found that patients with extremity and trunk wall soft tissue sarcoma and a low predicted overall survival had a better disease-free and overall survival when adjuvant chemotherapy was used. And they also found that adjuvant chemotherapy halved the risk of death in the high-risk participants. So this may reconcile some of the controversies and some of the disparate outcomes in prior adjuvant studies. So with conclusions about the use of neoadjuvant chemo, we know that it's controversial. The standard of care, if you're going to use it, is using a combination of doxorubicin and ifosfamide for somewhere between 3 and 6 cycles. And the greatest benefit is in high-grade, large, deep extremity tumors. Therapy has to be individualized, accounting for patient factors, and treatment toxicities have to be discussed. There are numerous other agents that can be used in the metastatic setting, including non-FDA approved agents like gemcitabine, docetaxel, ifosfamide, and dacarbazine. I'm going to spend a few minutes just running through Pazopanib, which is approved for non-liposarcoma, soft tissue sarcoma, and it was approved based on an improvement in progression-free survival of 3 months compared to placebo. So this is certainly an agent that can be used. Trabectedin was approved again based on an improvement of progression-free survival from 1.5 months to 4.2 months. And this agent in its study was compared to dacarbazine. And then Eribulin is a drug that's FDA approved only for liposarcoma, and it was approved based on an improvement both in progression-free and overall survival compared to dacarbazine. So a reasonable option for people with liposarcoma. There are numerous other histologies that I don't have time to run through today, but it's important to know that many of these histologies that have a very low incidence per year have very specific treatment paths that can be considered. For example, angiosarcoma we've seen some success with checkpoint inhibitors as well as single agent taxanes. Alveolar soft part sarcoma, we've seen success with both tyrosine kinase inhibitors and checkpoint inhibitors. PCOMA, we've seen success with mTOR inhibitors, and solitary fibrous tumor, TKIs, as well as regimens like temozolomide and bevacizumab. So important to keep in mind that all sarcomas are different, and so there are lots of nuances in treating some of these rarer histologies. What about immunotherapy? So immunotherapy has revolutionized the treatment of numerous cancers recently and has received FDA indications for lots of cancers, with the exception of sarcoma. If we think about the timeline of immunotherapy in sarcoma, back in the 1890s, when Coley was injecting streptococcus, he was actually injecting them into sarcoma and seeing responses, so potentially hints of efficacy of immunotherapy even 150 years ago. Cytokines plus chemotherapy have been studied with middling success. Most recently, the most promising immunotherapy in sarcoma has been adoptive T-cell therapy, and we've seen some success with checkpoint inhibitors. This is a summary of a few of the studies that have occurred. I'll just draw attention to these 3 because we've seen success with undifferentiated pleomorphic sarcoma, angiosarcoma, and alveolar soft part sarcoma with response rates somewhere between 23 and 42%. And again, this is a slide looking at combinations of immunotherapy plus TKI or chemotherapy. And again, alveolar soft part stands out as a sarcoma that has a very high response rate to the combination of pembrolizumab and axitinib, with a response rate in this study of 55%. And this is particularly impressive given that prior to this, there was really no effective therapy for this subtype of sarcoma. So Conclusions about immunotherapy and sarcoma: histology-specific trials are providing useful information, but we still have a lot more to learn. Biomarkers of response certainly need to be identified. We have not been able to do that thus far. And immunotherapy really is still best given to sarcoma patients within the context of a clinical trial, because we just don't know who benefits the most. One comment about next generation sequencing, as this is very common in oncology in 2021, it can be very helpful in diagnostic dilemmas, particularly to help us refine the diagnosis, particularly in those sarcomas that are translocation associated. Sometimes it can find a truly actionable mutation and maybe open the door for clinical trial treatments. There are some challenges though. Our tumors are often very necrotic, and so that can limit the yield of this testing. And unfortunately, the bulk of commonly identified mutations in sarcoma are not truly actionable, things like P53, RB1, and ATRX. And sarcomas are very rarely TMB high or microsatellite high. But it is very reasonable to send this in metastatic patients with metastatic disease, or if the diagnosis is questionable. So sarcomas are a very complex group of mesenchymal neoplasms. Prior to the initiation of therapy, patients should be evaluated by a multidisciplinary sarcoma team. Doxorubicin and ifosfamide remains the mainstay of neoadjuvant treatment, and doxorubicin alone is the mainstay for metastatic disease. Histology-specific treatments are increasingly important, especially for indolent or chemorefractory subtypes. And immunotherapy has a place in sarcoma, it's just not yet well defined. And lastly, there are lots of ongoing trials to advance sarcoma care. Thanks so much for your time today, and I'm happy to take any questions.